There we go. Right, we are now recording, so I'm going to welcome Andreas Kremer, who is all the way from Switzerland, who is going to answer your questions today. So we have people here in Click Meeting, we have people here in Facebook, and we have Andreas and I live online. So as ever, we will start with the caveat that Andreas is going to provide you today with general medical information. He's not going to give you any personalized medical advice. And what we will discuss today will not take the place of your consultation with your own healthcare practitioners, but hopefully will empower you in your conversation with them. Andreas, welcome. Thank you. Have I missed anything?
No, that's wonderful. Also, a very warm welcome from my side, and I'm looking very much forward to this webinar today.
Wonderful. Good, 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 good. Right. We are going to introduce you to the concept of A and E. So, if anyone here is watching from anywhere out with the UK, you'll have no idea what A and E means. In the US, I believe you call it the ER, which is the emergency room. And in the UK, it's the department, which is for accident and emergency. So that's what A and E is. So we had a question that came in with regard to somebody who was at A&E. So they have PBC, they have AIH, they have cirrhosis for all that their LFTs are normal, and they're asking about pain and analgesia. So what would be the best painkiller to take if that's where you are um, with your liver condition?
Absolutely important question, which we are facing on a regular basis. I personally think the amount of painkiller is more important rather than the substance itself. I also accept low doses of paracetamol. I'm not strictly against that, but once you have low doses, meaning up to 1 gram per day, this is even in a cirrhotic stage acceptable if this is compensated. If you want to have a less hepatotoxic drug, then I recommend metamizole, or often called Novalgine. This you can receive as drops or as a pill. Um, you can use 2 to 3 gram even in advanced disease stages without a problem. And I like the combination with codeine because this augments the analgesic effect. And similarly, non-steroidal antimuretic drugs, NSARs, such as ibuprofen, are also okay. Please keep in mind, it's all about the dose. If you use lower dosages, that's, I think, all acceptable. And if you need more, if you say I'm not sufficient with, let's say, 800 milligram of ibuprofen per day, then you add, or you intermittently switch between metamizole and ibuprofen, every 6 to 8 hours, so that you combine two different drugs. And that is often of help to have a sufficient treatment for, these acute pain situations, headaches, whatever it is in the end. Keep in mind, for short term, this is in most cases never a real problem if you use these low dosages, but don't do that on the long run. So if you require that for many weeks, if the pain is not resolved, then you should clearly think about other drugs and need according medical advice.
Okay, perfect. Thank you. I appreciate that. So, Andreas, I'm going to ask you about cholesterol. So, we've got somebody who now their cholesterol is very high, and it's a number that makes me think that it's a different unit that we're used to. Because our cholesterol tends to be kind of 3, 4, 5, or
Yeah,
6.
the millimolar indication, and this is milligram per deciliter, the
Okay.
300 here.
Okay. Right. Perfect. So somebody's asking about the very high cholesterol. So I'm actually going to ask you, if you will, can you just give us a basic overview of cholesterol and PBC, please?
Yeah, I think it's important to state that in PBC, there is very often a hypercholesterolemia present. And the reason for that is that there is a specific lipoprotein, which is called lipoprotein X, which is formed by biliary cholesterol molecules, and that runs in the LDL, so the low density lipoprotein fraction. It cannot be quantified per se with regular measurements, so it always is included in the LDL fraction, and this counts to the total cholesterol. So if you have PBC, it's very common that your total and your LDL cholesterol is increased. And now there is the big but. This does not mean that you have an increased arteriosclerotic risk or increased risk for cardiovascular events. And I think this is important. There is even data illustrating that the lipoprotein X, which is typical for PBC, is associated with no increased risk for arteriosclerosis. And to be honest, how we treat this hypercholesterolemia, we don't treat that in the absence of other risk factors. So if you have increased cholesterol and PBC and you have no diabetes, do not smoke, you have a negative familiar risk for cardiovascular events, you have no arterial hypertension, we don't treat that. We just observe that. Only if there is an additional risk factor, we would treat it as we would treat it in everybody else without PBC. And I think this is important to note. And these are also the guideline recommendations for our PBC patients.
Wonderful. All right, that's helpful. Thank you so much. Right, here's a question. I didn't know that LDL was low density lipid.
Yeah,
Thank you.
it's low density lipoprotein. I think in this question, it's important to state that the the person who wrote this question also stated that HDL, so the high density lipoprotein, is also very high. And to be honest, we in particular look at the ratio LDL to HDL. And if that is increasing, if that is beyond 3, then we think about a considerable cardiovascular risk in the presence of cardiovascular risk factors, of course. But if you have a very high HDL, then the ratio is small because you divide LDL by HDL, and then this is rather indicative of a protective situation where you
Okay.
shouldn't bother too much about.
All right, brilliant. That's really reassuring. So thank you. I appreciate that. Okay, now here's something I know absolutely nothing about. Now I know that will surprise you, Andreas, but here's the question. Um, my friend has PBC and cirrhosis, and she was told there is an immunotherapy to help her, but the main side effect is hair loss. Are there any immunotherapies in PBC? Either that, with hair loss as a side effect or even without hair loss as a side effect?
I mean, if you look into the internet, if you look into literature, there are still these statements that PBC is an autoimmune disease. And I personally think this is misleading because if we think about an autoimmune disease, we always associate that the typical immunosuppressive drugs, such as steroids, glucocorticosteroids, azathioprine, mofetyl mycophenolate, tacrolimus, whatsoever, that they should be working. And if we have the classical autoimmune hepatitis, AIH, that is really responding to these drugs. But what we have learned in the past decades, there have been many studies have been performed with these immunosuppressive drugs, methotrexate, tacrolimus, and so on. But we have learned that these drugs are not effective in our patients. And in that regard, um, irrespective of the drug which is now thought to be effective, there is no data supporting that. And whether this causes hair loss or no hair loss doesn't matter because the drug is not suitable for our patients.
Okay, all right, That's good to know. Okay.
Interestingly enough, that if the underlying baseline treatment is a bile salt, it's a physiological bile salt. It's ursodeoxycholic acid, which we all have in our body, which we only enrich by our treatment. And the second line therapies are targeting transcription factors in the hepatocyte, in the cholangiocyte, and other cells, and they increase the secretory function of these cells. So all these substances which should be secreted into the bile, these transporters, they are upregulated. The secretory function is improved, and that is the mode of action of the available in and off-label therapies so far.
So, okay, noted. Thank you. Helpful. Okay, on the subject of medications, so we have another question here. So this is a cracker. So it's to do with fibrates, urso, and oca, and licensing. So I'm going to ask you a specific question in a second, but can you maybe talk about urso, oca, and fibrates? They're part in the jigsaw, that is PBC treatment, and what it means to be a licensed or unlicensed therapy, please. A nice, easy one to begin with.
That's the easy one. Yes, I fully agree. So we have two licensed drugs. What does that mean, licensing? Licensing means that a pharmaceutical company or investigator-driven study is performed, and that a certain compound is investigated, first in very small groups of patients, sometimes first in healthy volunteers, and then in small numbers of PBC patients in that case, and then in larger cohorts. And there is a process which we call phase 1, phase 2, phase 3 studies, where we first look for safety, and then we look for efficacy. These are the dose finding studies where we figure out which dose is needed to have a certain benefit in a patient. And when the effective dose is known, then it's proven in a large cohort that it works. And this has been done for ursodeoxycholic acid and obeticholic acid as first and second line therapy. And this means that there is a lot of safety, a lot of toxicology studies, and this is then a huge data package is then transferred to the legal authorities, the European and medical agency EMA, and the Federal Drug Agency FDA of the United States, and Swissmedic, for example, specifically for Switzerland. And then these legal authorities look at the data very carefully and finally decide whether this drug will be approved for treatment. There are still a lot of details I don't want to go into, but this is the regular process of licensing a drug. This takes many years. And once the drug is in label, you can go to the pharmacy and buy that. Now, what we also have is off-label drugs. And off-label drugs are then drugs which have been developed for, let's say, to treat hypertriglyceridemia, such as fibrates, very old drugs. And people have used this to lower lipids in certain patients. And there must have been patients with PBC who have been treated, particularly because cholesterol was increased. And then smart people have observed, okay, the liver values improve, alkaline phosphatase improve. And then even smarter people said, okay, let's do a trial, let's look at that. And this has been done in PBC, a huge study called BETS-URSO trial, 100 PBC patients, 50 were treated with bezafibrate and 50 with placebo control for 2 years. And indeed, this trial has proven that drug works. It reduces alkaline phosphatase as a surrogate marker for the disease quite efficiently, actually, and it was published in one of the very best journals of the world, the New England Journal of Medicine. So this data then has given the support that also this drug which is not licensed for the treatment of PBC is beneficial of our patients. And as it is extremely expensive to perform safety studies, larger studies, to go through the process of negotiating that with EMEA, FDA, and so on, um, it, it really needs enormous amounts of money. And this can only be made by industry. However, if there is a drug which is very cheap, there is no interest of industry to support that, and that's why these drugs remain then off-label drugs and are not, you know, in many cases are not then undergoing repurposing. So meaning that, you know, the label, so this is this little piece of paper which is in the drug box, where there is stated, okay, so far you're allowed to treat hypertriglyceridemia, for example, that there would also be the indication PBC in the end. And this is
Yeah.
the reason why these drugs often stay then off-label, and this is the reason why we have now these in and off-label drugs for PBC.
Okay, perfect. Thank you. That's helpful. Now, I need to be mindful what I ask you because we're aware that there has been phase 3 data that's been published at the AASLD in terms of new medications that may or may not be possible um, to be available in the near future. But I want to ask you about, classic URSO response. And then if people don't have URSO response, they will tend to normally go on either OCA or a fibrate. And then there are other medications that seem to have similar numbers. So I'm going to generalize in the fact that of the people who don't respond to URSO, about 50% of those people, give or take, will respond to OCA, and about 50% of those people, give or take, will respond to fibrates, and about 50% of those people, give or take, respond to the new therapies that have been on trial. But some data that's come out was with the combination of bezafibrate and OCA together. Now, I think that was published at AASLD as well. And
Correct.
so I'm going to ask you, I guess, if a patient has gone from single therapy to double therapy and then they're looking at triple therapy, can you just give a little information about that journey and again a little reassurance as to why and how that can be good practice and how that helps the patient?
Yeah, I think this is now going into further details here. I personally think, when we talk about these triple therapies, we talk about a small percentage of patients who are on a second line therapy, whether it's fibrates or whether it's obeticholic acid, and they are still at risk for disease progression. That the easiest way is seen if you look at your print of the laboratory results, if alkaline phosphatase is still significantly increased, if bilirubin is maybe slightly increased, um, and if you are, maybe not so significantly increased, but if you're a young patient, you should always consider that normalization is the ideal goal if you're a young PBC patient. And young then means below the age of 50, maybe even older. 62 is a current publication indicating that those are the patients who would also have a benefit for normalization. Um, and and other factors such, signs that the liver disease is already, advancing, that I have more scarring tissue. There are many factors which should be taken into account. Now, if one or two of these factors are present, and the physician and the patient thinks we should do more, then you could think about triple therapy. And indeed, this has been done in the real life setting. There have been publications showing that this indeed works. And from a pathophysiological understanding, this makes sense because we target different signaling pathways in the liver. So with URSO, we target signaling pathways. With obeticholic acid, this is an farnesyl X receptor agonist, we are targeting signaling pathways. With fibrates, we are targeting PPAR receptors. And when we take these activations together, we have a stronger effect, a stronger effect on the secretion of the liver, secretion of biliary molecules. We have a stronger anti-inflammatory component, meaning that the inflammation in the liver is better controlled. And we may even have antifibrotic properties, meaning that the amount of scarring tissue could be reduced on the long term. This
Yeah.
is not clearly proven. There's some weak data on that, but I think I could imagine that the longer we treat those patients with either the one or the other drug or in the combination, that also on these important factors we could observe a benefit, which then on the long term would result in improvement of overall survival, less necessity for liver transplantation. And for the one and the other drug, there are already data out which have been, investigating large national registries, for example, in Japan for fibrates, or another trial compared obeticholic acid treatment over 6 years with large registries, global or UK PBC cohort.
Yep.
So yes, indeed, there is data that these drugs do not only improve what the lab print out, but also really meaningful hard clinical endpoints, as we say. And I think in that regard, yes, I think this is a very interesting approach. And we have seen first results, and I think larger trials have to prove that this is of benefit, and which patient group has the strongest benefit. I think this is also quite important to answer.
No, perfect. Thank you. I appreciate your answer. Thank you so much. Exciting times. Right. Here's a great call. Now,
Absolutely.
in the COVID era, we started using this thing like telephone clinical appointments and video clinical appointments and all of these kind of things. So the question is, how often should someone with PBC be seen in a clinic as opposed to, say, a phone call or a video call?
Yeah, that is a good point. I think it very much depends where you are and whether such an opportunity is offered. I think if you have a smoothly running PBC, meaning that your lab values are normalized, if you don't have signs of advanced liver disease, if you don't have a significant symptom burden, meaning significant fatigue, pruritus, we see those patients once per year. And
Okay.
I would think that this is sufficient. And if your GP or local physician sees you once in a while with a video call, I think this is okay. The question is then, how often should I come for a lab drawing? I think twice a year should be somewhat the minimum. If everything runs very smoothly. If that is not the case, I think you need it maybe every 3 months. It really depends on many factors. But if you feel good, if everything is fine, I don't see any reason not to do that on a video or a phone call. I fully agree. But drawing blood should be done once in a while, a little bit depending on the lab values, the disease stage, and so on.
Yeah, perfect. That's helpful. So, in very short, the answer is personalized medicine. So, looking at where you are as a patient. And if you have any questions, please do feel free. Get in touch with us at the foundation and we'll see if we can help you in this part of your journey. Okay. Now, if I asked to go from URSO from 4 times 250 to 2 times 500, how likely is this to be honored? So I'm guessing, how likely is the doctor going to say yes if I ask for that change?
I would say yes. I would definitely directly do that because you have 50% less pill burden, no? And after 3 months of distributing that over the whole day, I would also agree to only take that in the morning or only in the evening, that you even have less burden of splitting that throughout the daytime.
Okay, perfect. Ideal. Thank you very much. Um, we've talked about UDCA. Can we talk about TUDCA?
Sure, we can. What do you want to know?
So somebody is a weekly positive M2, but they say it's negative AMA. So I'm not entirely sure I understand what that means. Normal FibroScan, normal ALP, but it is at the higher end of normal. So they've not been diagnosed. Would they or can they take the supplement TUDCA to support their liver?
Well, you know, if you only have an anti-mitochondrial antibody without AMA M2, and then it depends a little bit on the titer, um, I think we are not yet there with the diagnosis PBC. We call that at best AMA negativity. I would definitely look for the PBC specific anti-nuclear antibodies. In particular, the immunofluorescence pattern is important so that
Yep.
you do not only quantify them, but also have a look under the microscope what they stain. And in the ELISA, you have specifically antibodies against proteins called GP210 and SP100. And if they are positive, then I think we are more towards a PBC antibody pattern. If it's only AMA and if the titer is very low, I would, control that within a year and check whether the titer goes up or whether it just disappears again. We see autoantibodies, in these ELISAs, they come up and just, are gone again. So in particular, if you have lower titers, I wouldn't put too much weight on that. And if lab values, alkaline phosphatase in particular, if that is normal, then we would never treat it. We would just observe, we would control in a year, and don't do anything. So there is no need to treat these early disease stages. It would only change if you have then significant symptom burden. If you suddenly then develop pruritus, that would change something for myself personally. We know that there is symptom burden or a significant fatigue or so, and when this may then hint towards PBC, then I would start, but I would start with urso. The point is that the unconjugated urso is much cheaper than the conjugated one, and once it undergoes one cycle through the liver, it's conjugated anyway. The liver puts in a glycine, puts in a taurin. In the human situation, more glycine than taurin, but it will be conjugated anyway. So it doesn't matter whether you use a conjugated one, because that will be done by the liver anyway, and it will be taken off by the bacteria in the gut lumen again, and then reconjugated in the liver. So this is the typical enteropathic cycle. So you take that up to the liver, you secrete it back, and you have several times per day these bile acids undergo this enteropathic circulation, and there's really no need to use anything else than unconjugated ursodeoxycholic acid. But we only treat patients where we have a definite diagnosis of PBC, not an autoantibody titer. We would only, and I've just seen this Monday a family where the mother has a PBC, and she has two kids, a female and a male kid, and the girl, she's in her 20s, she has already this very high anti-mitochondrial antititer of 1 in 10,000, and also AMA M2. She's also positive for SP100. So she has really this antibody pattern for
Mhm.
PBC, but lab values are low normal. I don't treat her. I now control her every year. She has no symptoms. We control that. We know that a certain percentage of these patients will develop PBC at some stage in their life.
Yeah.
But there is no reason to take now 10 years of urso, and maybe you will never develop PBC. I think there is no need for that. And we observe her. She comes then once in a year. And I think this is absolutely sufficient. So yes, there is this pre-monitory situation. you should control for that, but treatment only if you have either increased lab values or symptoms.
Perfect. That's really, really helpful. I'm going to apologize to people if you're watching here on Facebook, or if you're here in the room, and I had a ridiculous smile on my face. I was smiling at the level of detail that now we can talk about PBC, the understanding of the microbiology, the understanding of the processes. I remember being at a liver conference a few years ago, and I was like, how does URSO work? And there was this blank stare between the physicians where they all kind of nodded to each other to say, are you going to answer this? Because I'm not answering this. And now we have a much, much greater understanding of what actually is going on a cell by cell level. And it's just wonderful to see and to hear and to be able to share. So, Andreas, thank you for that. I'm so grateful.
It's a pleasure.
Right, I've got a couple of questions about PBC okay? So the first one, is there a link between PBC and being cold?
No, there is no link. There is a link between more urinary tract infections and PBC. So if you look at large data sets of PBC patients, urinary tract infections occur more commonly in women with PBC, but the regular cold is not typically increased.
Sorry, I meant being cold, not having a cold.
Oh, sorry. I'm sorry
Feeling
for
cold,
that.
sorry.
Freezing. Okay.
Yes.
Yes, I mean, this is something else. Being cold is, something very subjective. If you have additional symptoms of a not regularly working thyroid gland, for example. So if you have a dry skin, if you may gain weight more easily, if you lose hair, then you should always consider controlling for a thyroid dysfunction. And this is important because PBC is an immune-mediated disease, and also the hypothyroiditis Hashimoto, meaning that this is an immune-mediated destruction of the thyroid gland, where also immunosuppressive drugs don't work, actually. But up to, depending on a little bit which cohort you looked at, let's say between 10 and 30% of PBC patients also had this immune-mediated destruction of the thyroid gland. And if your thyroid gland is not producing the thyroid hormones anymore, so they are abbreviated as FT3, FT4. You can measure that. You can also, as a screening measure thyroid stimulating hormone.
Yeah.
And the brain, or parts of the brain, produce this hormone to stimulate the thyroid gland to produce more hormones. And if your hormone level is low, then more of this stimulating hormone, TSH, is produced. And if these values are increased, so this would be the screening parameter for this insufficient thyroid gland, or the insufficient production of hormones by the thyroid gland, then you should be treated for that. You do that by substitution of these hormones, very simple.
Yep.
And so yes, I would recommend in this case to control for the thyroid gland function if you feel cold, if you have a PBC. And I actually recommend that to my patients, to control for that once a year. Because throughout the disease course, there's always the risk to develop this additional immune-mediated disease, and it's a very cheap and easy way to control for that. And yes, this would be my very first step. But there are many, many, many other reasons to feel cold. So, the heart, the blood pressure, whatsoever. I mean, many, many factors play here a role.
All right. Perfect. Thank you. That's helpful. Okay, my next question. Somebody has PBC and they've been given amlodipine for high blood pressure. Now, they found research that says that amlodipine is linked with AST, ALT increases. So, is there anything in amlodipine? Is it linked to like a drug-induced liver injury? Is it bad news to take with PBC? What do we know?
Well, I give antihypertensive drugs to many patients,
Okay.
and you know, um, I think amlodipine and other calcium antagonists are routinely used in millions of people. And indeed, yes, also these drugs can result in mildly elevated, often temporary increases of transaminases. And to my knowledge, this is very uncommon. Um, we hardly see that, and these are normally case reports where this is linked to. I would not consider this to be a problem in my PBC patients. We regularly treat also our patients with beta blockers, with calcium antagonists, with angiotensin converting enzyme blockers, and so on. I have never had any issue here, so for me that wouldn't be any problem at all.
Okay. Perfect. Helpful. Thank you. Another question. So this came about round about your pain answers earlier. So first off, if you're asking this question, I hope you're okay. So somebody's just saying they've just broken their femoral neck, which doesn't sound good. I'm not a doctor, but
No,
that doesn't sound good. So I hope you're well, and hope you recover very quickly. But they're on ibuprofen and Tilidin. Is Tilidin bad news in any way if you've got PBC?
no, I mean, of course, tilidine, as other opioids, they are metabolized by the liver, and it very much depends on the disease stage. So if you are in a pre-cirrhotic stage, there's no reason to bother at all. I mean, of course, always don't, overdose these drugs. But if you use that for a temporary time in a regular dose, you're non-cirrhotic or not a decompensated cirrhosis, then I wouldn't foresee any problems here. So I really keep the fingers crossed that this bone problem heals well. Again, I think if we talk about bone problems, it's important to state that in any cholestatic liver disease, including PBC, we often see an earlier bone mineralization loss. And if we talk about now fractures or reduced bone density, it's important to state that PBC patients should undergo bone density scans, so-called DEXA scans.
Yeah.
And depending on the result, you should repeat that between 1 and 5 years, um, just to control whether the mineralization is stabilized, if it's reduced, or if it's increased after an adequate treatment. So osteopenia, osteoporosis, so loss of bone mineralization, is very common and should be early treated. And if you have a significant bone loss, um, vitamin D is not sufficient. You then need additional drugs such as bisphosphonates and others. I think this is very important to see the whole patient. And in that regard, you should consider, if that has not recently been done, to check for that by osteodensitometry, a DEXA scan, as it is called in medicine language.
All right. Perfect. Thank you. Next question. PBC and kidney disease. Is there a link?
Not directly. We don't have a direct link in the early disease stages. We have a link between the liver and the kidney in very advanced disease stages, when we talk about decompensated liver cirrhosis, when we have ascites. We can have a hepatorenal syndrome that already indicates that the liver and the kidney have a combined syndrome. But this is only present if you have ascites, so if you have a lot of water in your belly, which is there because the liver function has deteriorated, and then also the kidney can have a problem. But at an early disease stage, up to the compensated liver cirrhosis, there is no clear association between PBC and any kidney disease.
Wonderful. That is helpful. PBC and anesthetic. If you have a general anesthetic, are you more prone to things like dizziness, nausea, ache around the liver area of the body, anything like that?
Again, it's more or less the same. If you are, in a non-cirrhotic stage, if you have an early disease stage or only a moderate fibrosis, I don't foresee any problems with
Yeah.
surgery, with anesthesia. That's not a problem. This may only become a problem when we talk about patients with liver cirrhosis.
Yep.
There are certain calculators where risk scores can be performed. It very much also depends whether you are in a compensated or in a decompensated stage, whether you have portal hypertension, meaning that the blood flows through the liver is so much hampered that the blood pressure in the portal vein is increased. That can be measured. There are indirect, hints towards that, and all these factors then play a role. So only in these very advanced disease stages there is an increased risk, and that has to be judged then on an individual basis.
Wonderful. Okay, thank you. Helpful. And the last one in the PBC and section is, wish me luck with this, clobetasol propionate cream. So the question is, I've been prescribed it for lichen sclerosis. Is it okay to take with PBC when you have cirrhosis?
Um, I all the topical stuff you put on your skin has the potential of absorbing certain substances, and in most cases this is not a real issue to my experience. But I always say I would control liver enzymes on an individual basis, and if the cholestasis parameters and transaminases remain on a comparable level, I don't foresee any problem here. So the topical treatments are in most cases safe, even in the presence of cirrhosis.
Perfect. PBC and thyroid cancer. Any links?
No, there is no link. There is nothing reported in the literature. Of course, thyroid gland cancer can occur. It's not a very common cancer, but it can occur. But to my knowledge, there is no link ever published between thyroid cancer and PBC.
Okay, thank you. And the very last one of all the last ones in this section, PBC and Meniere's disease.
Morbus Meniere is a disease of the inner ear. This is a very rare disease as well. No linkage, in my point of view, between these two disorders.
Wonderful. You know stuff. How do you know about ear disorders? That's amazing. So perfect. Right.
Yeah.
Okay. Right. I'm going to. So we've had a question, which is to do with if brain fog. Now the question. So the person who's asking this question has PBC, has compensated cirrhosis, and has normal levels of ammonia. Okay. But their question is in and around brain fog. So can you maybe talk a little about brain fog, or my mind's gone blank. How ironic is that?
Who has the brain
Uh,
fog now?
brain fog, I'm calling it a PBC moment by proxy. So brain fog, cognitive dysfunction, and then HE, hepatic encephalopathy. So again, can you maybe differentiate them and just talk a
Yeah,
little about them,
yeah.
please?
I think this is a very important issue. If we talk about symptom burden in PBC, we are well aware that the common symptom trias is fatigue, pruritus, and Zika syndrome. So pruritus is itching. That is very clear. We can distinguish that. We have to keep in mind that there are many other causes of pruritus. So the skin must look normal at first sight, and it should, you know, be not linked to any dermatological disease, for example, or primarily skin alteration. If we
Yeah.
talk about fatigue, then we have to distinguish here. It's not the common exhaustion we have on a Friday afternoon after a hard working week, or maybe the younger people listening to that after an extensive weekend of partying, then the Monday morning where we hardly get out of bed. No, this is not the case. It's really something else. It's really an symptom, a disorder, which is linked to PBC. In particular, it can be there very extensive and has two components, namely a more peripheral component and more a central component. And the peripheral component would be more, the exhaustion of your muscle function, meaning that if you want to, do sports or walk more extensively or climb or whatever, that you feel that your muscles are exhausted much quicker than at former times, or compared to your friend you're doing the exercise who has no PBC. And this has been nicely illustrated. I think also Dave Jones published on that. Your muscle produces more lactate and is earlier exhausted. Now, this is one component. So this, the strengths, the muscle strengths, and things you can, describe quite well. And the other part is central fatigue, and this is this brain fog. Like the problem, I have problems to remember things. I have problems to concentrate on discussions, on my work, on whatever it is. So it's like being standing in the fog and not clearly seeing where to go, what to do, and this can be a significant challenge, leading to the change in your daily routine, that people stay up very early because they say in the first hours of the day I'm still capable of mentally being very active, of being sharp in my thoughts, and from noon, the early afternoon hours, this is totally lost. And I think this has a very strong impact on people. If you cannot concentrate anymore, if you cannot remember things, and it has to be clearly distinguished from any other cause, in particular hepatic encephalopathy. So
Yeah.
ammonia levels is something anyway. When there have been full symposia on ammonia levels and whether it's suitable to measure or not. It's a very unstable molecule. To be honest, you have to be careful. I would only determine that in an in-hospital patient at all. But this has nothing to do with hepatic encephalopathy, which occurs when the liver function fails, meaning that we are in a very advanced disease stage where we are in most cases in a decompensated liver function, when we have ascites, when we have an infection, when we have a bleeding, when we have, electrolyte dysfunction, and so on. Then we call it hepatic encephalopathy. And this has nothing to do with this fatigue situation in PBC, which can occur actually in very early disease
Mhm.
stages, where we hardly see any alterations in the liver, and this can be very, very have a strong impact on patient activity, patient health, and quality of life.
Wonderful. All right. Thank you very much. Right. We've got 7 minutes, so we'll try and get in the quick fire round now. Um,
Okay.
so I've had a question in terms of somebody newly diagnosed with PBC. They've had pneumonia, and the doctor thinks that this may be that the PBC is having an impact on their susceptibility to that pneumonia. Any thoughts?
I would say a definite no.
Okay, perfect. Now, interesting question. Somebody has finally got their children to consent to see a gastroenterologist. Now, as a patient advocate, I would have questions about that. But what tests should be run on an annual basis to check for a possible PBC hereditary link? Now, that's quite a big question, and there's a whole lot of places
Yeah,
you can
yeah,
go there.
yeah.
So, can you
So
go as many places as quickly
yeah,
as possible?
yeah. So I think it's important to check. Keep in mind that first degrees in your family being female have a significantly higher risk than males. I would still check males from an age earliest, let's say 20. Um, Now, if you check at first sight, go for autoantibodies, antimitochondrial antibodies, AMA-M2, and the PBC-specific antinuclear antibodies are the ones I would test. And liver tests, transaminases, alkaline phosphatase gamma GT. And when you do that once, and everything is normal, you can repeat that in 5 years. If you have autoantibodies, but still normal liver function, control alkaline phosphatase, I think, is the most important one on an annual basis.
Yeah.
If liver's enzymes are up, but no autoantibodies, think about any other liver disease, viral hepatitis, alcohol, fatty liver, whatever, many other things which are way more common than PBC. So keep that in mind. And if you have both, if you have alkaline phosphatase increased and the autoantibodies, then it's a PBC, and then you have this familial incidence that several people in the family have PBC.
Okay, perfect. Thank you. So, we've had a kind of follow up question in terms of, is PBC hereditary or genetic? Can you maybe say a little about that?
It's not a typical hereditary disease. So we have, typical autosomal dominant, autosomal recessive disorders where we have, clear-cut genes when they are, for example, in the autosomal recessive situation, if two sick genes are transferred, one by the mother, one by the father, then your daughter or son has a certain disease. There are many things we can discuss around it, but no, this is not the case. There is certainly a genetic background which makes you more susceptible to develop this disease. But we believe that there's still the need of exogenous factors. We have not a real clue what these exogenous factors are, whether it's bacteria, whether it's viruses, whether it's toxins. There are many hypotheses, also preclinical models which have studied that. I think this remains unclear. There is also the hypothesis that there is only a, biliary damage, which then results in, an immune response in your biliary cells, biliary tract. This is still a matter of debate. I think, yes, you need certain gene alterations, genetic background, but this is not a typical hereditary disease which is transferred from, one mother to the next child and from the daughter then to the next child. No, this is definitely not the case. I would say it's roughly these PBC families we observe is rather rare. Depending a little bit on which literature you look at, it's up to, I think, 5 to 10% where you have these PBC cases more common in one family.
Yeah. Okay, perfect. Thank you. Last question of the day, I think, and it's an absolute cracker. So, I'm going to paraphrase. I want to just check I've understood the question correctly. So, in an ideal world, we would have normalized alk phos. And then we have kind of somehow managed to accept that an alk phos of lower than 200 is okay and not worthy of a second treatment. Now, we're now looking at trying to make a PBC paradigm where, with exceptions, normal becomes the new normal. So we want to get below that 130, 140 mark, if at all possible. And that hopefully is the direction of travel from here on into the future. The question seems to be that even if we get to normal, would it be worth triple therapy to even further lower the alk phos levels?
Yes, I strongly support the new normal being in particular, I think normal alkaline phosphatase. I think this is and bilirubin, of course, but in most patients, bilirubin will be normal. But AP normalization, I think, is a strong go for. And I personally think if you have a normalized liver pattern, liver function pattern, transaminases, AP, bilirubin being normal, I don't see any need to go for further therapies. We have understood that for bilirubin, the low normal is even better. We don't have any data for alkaline phosphatase, to be honest. But I think the overall survival is already so good when you have a full normalization. I don't foresee a real probability to have a further improved overall survival if you go to low normal for alkaline phosphatase. So I would think I would only let's presume the following. Let's presume you have ursodeoxycholic acid and you have a good response. AP is normal, but you have pruritus and you think it's from the liver. Yes, then I would bezafibrate to treat the pruritus and not to treat the underlying disease, but to treat the symptom burden. That would be an indication to do that. But otherwise, I wouldn't do that.
Okay, that's helpful. Thank you so much. So it's 3 o'clock. I will indulge myself, if I may, with one last question. So EASL Liver Congress is coming up, the ILC, the International Liver Congress. This is where thousands and thousands and thousands and thousands of people come together to discuss all things liver. My question to you is, why are you going? And what do you think it's going to bring PBC patients in the future?
Well, I think the ILC, the International Liver Congress, is the very best liver congress in the world. I think, of course, there's an American version of it, but for me in Europe, I think it's a very important congress. I have a lot of exchange. I learn a lot of new things. I think it's being there is being at the heartbeat of hepatology, being at the earliest developments, exchange with colleagues, discuss novel treatment strategies, novel developments in the field of liver diseases. Of course, I give talks, I present our own data, and can exchange also, with other people, patient organizations, colleagues. I think this is very, very helpful. It pushes the field strongly further, these events. And that's why I think they are so important, and why we are so happy that COVID has passed by and that we can be there again in person and exchange there. That is really illustrating us how much important it is to meet in person, because only sitting behind a screen for 5 days is just a total disaster. And listening only to talks in front of a screen. So I think, yes, these are the most important aspects why I go there. And I'm very much looking forward also to meeting you there and having good discussions on PBC, the development, not only in PBC, in many other aspects. Symptom burden is becoming more and more important. We see novel developments here, and I think this is a great opportunity we shouldn't miss.
Wonderful. Thank you so much. Andreas, you take care, sir. It'll be good to see you. All the best. Thank you.
All the best also, and thank you for the listeners and the great questions.